Hi, everyone. This is Patricia from the International Hospital Federation. Thank you very much for joining us today, and I hope you're all safe and well. The IHF is hosting this COVID-19 webinar and live Q&A series to share experiences, good practices, insights, and recommendations from our members and other organizations across the globe. This series has been created with healthcare providers for healthcare providers, including decision makers and those involved in preparing for and managing COVID-19. We hope the lessons you take away from this session will help you tackle the crisis. I would now like to introduce the moderator of this webinar, IHF CEO, Eric de Rudenbeck. Eric?
Thank you very much, Patricia. Good morning, good afternoon, good evening, everyone, and welcome to this webinar that will take us today to Lisbon, Portugal, in one of the major university hospitals of the country. We heard a lot, especially in Western country, that health services had many challenges to scale up ICU activities and organize COVID response. In addition to having no specific preparedness plan for a pandemic, it was often mentioned that budget cuts that hit most of these public organizations in the last 10 years has played a role. From that perspective, Portugal is a very interesting country because it has been one of the worst hit countries by the 2008 financial crisis and has got through a very severe public budget cut with major restriction for public services and has gone through a reform that reorganized health services, enhancing, by the way, the role of primary care. However, Portugal has kept a national health system providing universal health coverage. And if health professionals working in hospital can certainly point shortcoming and consider that they don't have all what they need to work in most proper condition, Portugal has done remarkably well in facing the COVID crisis by both taking early measures to avoid strong spread of the virus, but also by organizing the response to the challenges of taking care of COVID patients while keeping capacity to resume as soon as possible that activities for all non-COVID patients. So we'll have this example presented by Dr. Pinheiro that I'm going to introduce, but just before the introduction, let me emphasize that for the Q&A session, please focus on leadership, management, organizational issues, as the objective of this webinar series is to address this aspect and not to overlap with the many other webinars that cover the clinical practices. So let me introduce you Dr. Luís Santos Pinheiro. He is the Chief Medical Officer of the University Hospital of Northern Lisbon in Portugal. His career path is guided by a holistic, wide-ranging vision of medicine and healthcare with a specific interest in health education. He's qualified as a clinical investigator and has also qualification in health management and organization. Before his position in this hospital, he was the medical director of a Barreiro hospital, a general hospital, and he's graduated in, as I mentioned, in health management, epidemiology, and he's also teaching in the Faculty of Medicine in Lisbon. Dr. Pinheiro, the floor is yours.
Okay, good afternoon. Thank you very much, Eric, for those kind and comprehensive words. And also, I would like to acknowledge the pleasure that is to be here with you and all our viewers and listeners in order to try to share with you the experience of Portugal in a broad sense, and specifically our hospital, the Northern Lisbon, as you said, hospital center, University Hospital Center, that I will try to present to you in the next slides. I have a presentation that I will try to show you, and we'll go along with the images. So I call this adaptive response to COVID-19 pandemic, and I try to present you the experience of our university hospital. This response I can summarize my presentation and my talk to you, stressing the unpredictability of COVID-19 and the fact that it poses an urgency of action to all healthcare organizations, namely hospitals, and we will try to focus the major steps that we have been taken in this process that is dynamic, but it is also undoubtedly flexible and adaptive of our structure and processes. We will try to emphasize, of course, because it is essential, the pivotal role of healthcare professionals, because without their dedication and personal sacrifice, no hospital, no organization would have been able to deal with the different stages and the different challenges and difficulties that COVID-19 posed to all of us. I will try to separate this path with you in 4 stages. The first one, the awareness stage, well, where with the engagement of the whole organization and all stakeholders, we may become aware of the problem and the potential complications of it. After which we can make planification, designing the roadmap of the organization, foreseeing and anticipating the worst case scenario. After that, we tried and succeeded in implementing a stepwise approach of the changes in the organization, taking into account that the epidemiologic evolution of the pandemic is dynamic and many scenarios could present to us. And after that, that is the phase where we are now, we will focus on the relaunch of the non-COVID clinical activity because we need to try to not compromise the availability of the reserves that we still have to address COVID-19. So in the awareness stage, we started by looking at the evolution of other countries that already had positive cases of COVID-19. And we saw that in the 3rd of March, that is the date of the first case in Portugal, there were two distinct profiles of the curves. One pointed with the arrow that had an exponential growth of cases, and others in yellow and black. Those are real countries that I chose not to name because that's not the matter. And we became aware that there were different possible evolutions. And even more worrisome would be the evolution of the curve of deaths with different profiles, a more exponential one in red and yellow, or a more stable and flat curve as we see in the black line below. That also translated into the fatality rate that could be quite worrisome. Looking at these possible scenarios, we had the possibility to try to anticipate. And 1 month before the first case in Portugal, we already were dealing with some kind of worries regarding COVID-19 patients, in this case, not patients, but citizens that were exposed in Wuhan to the disease and that were confined during the quarantine they had in Portugal in our hospital. In parallel, we also designed and discussed either globally and institutionally the contingency plans that we would have to implement for COVID-19. And 2 weeks before the first case in our hospital, but after the first case in Portugal, or at the same time, we chose to designate an operative group for COVID-19 that acted as, along all this time, as a direct advisor to the board, a group that is multi-professional, centered by physicians, medical doctors, and nurses, and multi-speciality from infectiology, internal medicine, intensive care, pneumology, labor health, pediatricians, and with this broad constitution, this group served as advisor and a continuous center for the decisions that had to be made, because they were indeed they were and are indeed a fundamental stone for all this process. In parallel with all this, we prepared to play a full role as first-line hospital in dealing with the epidemic, creating a comprehensive and integrated healthcare structure for COVID-19 that included not only emergency room, dedicated wards, dedicated ICUs, laboratory testing for diagnosis of COVID-19 infection, and also in-house and specific and internal medical advisory line and availability for our professionals to use inside our hospital and not being dependent on third parties. All this context led us to be aware that a very troublesome path could occur. So we evolved into the planification stage, where we tried to planificate and expect a worst case scenario, but at the same time being able to have a stepwise and a gradual implementation if necessary. So we planified clinical and administrative process changes in the hospital, not only centered on patients and their relatives, but also alternatives to face-to-face appointments, namely the different forms of telemedicine, also defining the laboratory testing criteria for COVID-19 that is essential to make a proper use of the resources in this area. Also identifying non-essential clinical activity that could be cancelled or postponed, and having a serious bet in health professionals' protection, trying to always have available individual protection equipment and access to testing, laboratory, and all the circuits necessary for the protection of our professionals. And also a particular emphasis in communication channels, either internal communication channels, the classic ones, and also new ways of getting to different people regarding the disease, regarding the planification, regarding the future and the occurrence in the institution, but also outside, either to the patients and their families, either to the media, and also to the different stakeholders in our healthcare system. This planification included, of course, a need to make structural and organizational changes with the planning for dedicated COVID-19 areas in the emergency room, in the wards and in the ICU, but also having available COVID-free areas, either inside the bigger hospital of our hospital center, Hospital Santa Maria, that has around 1,000 beds, and we tried to have always COVID-free areas. But as we are a hospital center, we also have another hospital in the hospital center, that is Hospital Pulido, Valente. That is a smaller one, but also very differentiated, complex, and with very useful and complex infrastructures. So that we chose to be a COVID-free hospital in order to ensure safety for the patients that also tried and entrusted their health to us. These changes included the total requalification of the emergency room. As I said, these pictures represent the outside of the emergency room with the availability of movable structures, either tents or those more solid ones in the lower health, that complement the devices inside the emergency room that has already also different circuits, but also the change and the requalification of another area of the hospital in the upper left, that is not the emergency room, but now it is. It was not the emergency room, and now is. That is the COVID-19 ER. That's an image before opening. After opening, we could not make photographs because, of course, that is a red area. These changes also included the planification of multiple wards that would be recruited for the COVID response, the COVID-19 response of our hospital. That started with the first 21 beds in one ward of internal medicine, and would end, if necessary, in a last ward summing 308 beds in a total of 1,000 beds that we have. So 1/3 of our beds would have been recruited, if necessary, for COVID admission. In terms of ICU, we also had to make planification in advance in order to anticipate this area that is one of the more worrisome for all of us. We anticipated that the need for ICU beds would be quite stressing on the organization, and we tried to identify in advance the steps that we would have to take, and we prepared these units in order to activate them as needed, ranging from the first 8 beds in ICU to the full catastrophe scenario where 140 beds would be used in ICU. Starting with polyvalent ICUs, stepping into OR conversions, ward conversions, using neurocritic ICUs, surgical or other surgical ICUs and cardiac, and the last step would be, if necessary, the building of campaign ICUs outside the hospital. This was the plan, and these were the steps that we anticipated could have to be taken. Let's see in the next slides what happened. But all this planification had to be centered on people, their commitment and their effort, their motivation. So we had to call people and our professionals into this boat and planify with them how we would work, because we had to have, and in anticipation, people ready, available, willing, and to enter and work with all these wards, ICUs, and in the emergency room. So only with all these people that I show here and many more, was it possible? Would it be possible to take all the steps necessary? And we also emphasized the importance of teamwork. Teamwork was never so important in healthcare as in the context of COVID-19, because it takes us into the edge of our effort. And as this poster here says, it is a poster with professionals from our hospital that was used by our healthcare system to make the proper showing what was happening in this, and valuing the professionals, that says together we will win the virus. I don't know if we won it, but if not together, it would be completely impossible. All these planification efforts led to the phase of implementation, and the implementation took a stepwise approach, daily monitoring the evolution of the epidemic, activating resources in advance of they being needed, and having always the next step ready for activation before it was necessary. And also implementing and promoting intensively healthcare professionals' motivation, focusing on dedicated teams, and also having as needed and whenever possible backup reserves of professionals in order for them to enter into the system, into the different steps. So all this implementation also counted with the solidarity of a countless number of people, individuals, anonymous or not so anonymous, companies, non-profit organizations, countries, that helped us with individual protective equipment, with disinfectants, with food for our professionals, not only hamburgers, but many other, but this picture is just illustrating, because many of people dedicated to COVID are not locked in during 24 hours or 48, but have difficulty in going out. So this help was very important. And also with equipment, respirators, ventilators, monitors, different medical equipment that we received from a lot of people. This implementation would not have been possible without this help. But the implementation, as I told, followed the evolution of the pandemic. And now I add in this chart The red line, that is the line of Portugal, that this one, I tell you who we are. The evolution of the cases per million along the time since the first day, the 3rd of March, was quite flat. And the evolution of the death rate was also, and the fatality rate was also quite flat. So we had an implementation that didn't need to go until the last stages. But we had have been having along the time also a very intense labor in the area of testing. Our hospital alone has done, from the beginning of the pandemic in Portugal, more than 13,000 tests, diagnostic tests, RT-PCR, 6.7% of them positive for our hospital and other institutions, healthcare institutions and others. And the evolution of the epidemic in our hospital followed what was the evolution in the rest of the country, with a number of admissions in red ICU that were around 20 at each moment, and outside ICU around 40. A total of around 60 patients admitted at the same time in the hospital. So quite below the worst case scenario that we have anticipated in terms of our planification. With also a lot of discharges and a percentage of death around 1/4 of the admissions, not 1/4 of the positive cases. This meant that we only had to activate 3 of the wards that we anticipated that we could need, 20% of the potential that we planified. And this also happened in terms of the ICU. We activated 29 beds of the potential 177 if before catastrophe or pre-catastrophe, or even the 140 that could have been possible, but with very a lot of difficulty. But right now we have 21 beds activated. We have an ICU of 10 beds ready to be used at any time, but until now it was not necessary. So we came short of the need to activate all the device, all the planified infrastructure, luckily, but we were ready to do that. So at the end of this process, at the end of this initial process, we are now facing the need to relaunch at the same time as we continue to address and to take care of COVID-19 patients, because along this 1.5 months, 2 months of COVID activity in Portugal, a lot of patients without COVID-19, that are the majority of patients that in all our hospitals we treat along the time, need to be readdressed, need to be rescheduled. So we are now going in the process of resuming priority non-urgent surgery and procedures and priority medical appointments. We will continue to increase the importance of telemedicine, and we are ensuring in this time where some kind of openness of the society for the people is happening, we need to address in a stronger manner the safety for patients and professionals, keeping the safety distances within the hospital, addressing and using strict schedules for our appointments, maintaining and reinforcing independent circuits, and, as WHO said a few months ago, test in order for no patient inside hospital has COVID-19, unknown COVID-19. So I would like to end this talk to you with some general take-home messages, like we tried to be able to prepare for the worst, and we had the luck of being able to see what could be the worst, because the epidemic arrived us later than others, but while hoping for the best, always valuing organizational commitment and solidarity that were essential for some kind of success that we had within our country and our hospital, and also to try to cope with what we think will be a long-lasting dual hospital, COVID and non-COVID. Thank you very much for hearing me, and we'll try now to answer some questions, and I give the floor to Eric, please.
So thank you very much for this comprehensive presentation and quite impressive achievement, both in the way you have prepared, organized yourself, and the result you have met. One first question that we received, and that's, I think, an interesting generic question, is around the fact that, you know, having been in a university hospital, is that helping you to be better in capacity to organize and prepare the response versus a general hospital? Is it a question of, you know, size, a question of the qualification, or do you think any general hospital would be as well or set and organized to prepare a response than a large university hospital like yours?
It's an interesting question, and I would like to say that we have the privilege of being at a university hospital, and that gives us the advantage of having along with us the thoughts of scientists and of teachers. But that gives us mainly more responsibility, not giving less value to the ability of non-university hospitals to provide good healthcare for COVID-19 patients. That was the option in our country. Every hospital in Portugal had responsibility in treating COVID-19 patients. That was the way that we could be closer to the different patients along the country. We, as a big hospital, have increased responsibility, and namely in the areas of a more complex response. For example, ECMO, that is a specific form of treatment in the ICU, is not available in all hospitals. So some of them, namely ours, receive those patients. But the great value of being a university hospital is not to treat better our patients. I think all past hospitals, big hospitals or smaller ones, have treat well their patients. We have the privilege of having access to probably more precocious information and scientific information, and being able to participate in partnership with the scientists and the teachers in the developing of new solutions and a broader and easier way of flowing scientific knowledge, and also the responsibility to make it flow to other hospitals that don't have that privilege. So not in terms of the ability to treat patients, more in terms of the possibility to be more engaged and inside the scientific drive.
And in relation to that, I mean, as you underscore the fact that you moved very much in unknown territories and had to be agile, and did you have to change more or less during the response the protocols for treating the patients, or did you continue with the same protocols, or did you update it and change the protocols because you are a university hospital and you have all this capacity to analyze and eventually adapt?
Indeed, we have been changing the protocols. I don't say every day or every week, but quite frequently, because the knowledge is being built every day. So we started even before the broader rules that were disseminated to all the country. We started with some approach, namely in terms of drugs for this patient, and also procedures and internal organizations within the ICUs and the wards. And we have been changing them in terms of the indications and the contraindications of some drugs, introduction of other drugs. So the protocols are have been quite flexible and dynamic along the time, and they are still changing along with the availability of solid, or as possible solid, scientific evidence to support those choices.
And a question also along that, which is more for the staff.
Mhm.
Same thing for the protection of the staff and the use of N95, mask or others to protect the staff versus the surgical mask versus no mask. Have you changed also the protocols, and have you had any need to also mitigate what you wanted to do because of shortage?
Not exactly. We started in the beginning of the epidemic with some difficulties that were overcome in the availability of more specific and broad availability of some individual protection equipment, but never reflected in the ability to effectively protect our patients and professionals. And we differentiated the indications for those protections according to the setting where it happens. For example, right now and for some weeks from now, every person that circulates inside the hospital has to wear a mask, a surgical mask that is provided at the entrance either to professionals or patients or visitors, whoever. In the wards and in the clinical settings, the protective equipment is dependent on the setting. In the COVID-19 wards and ICUs and emergency rooms, the full gear is available and used by the professionals inside. And in the other ones, the protective equipment is adapted for the indications in those settings. So we have an obsession, let's say, for the protection of our professionals, not only through the supply of individual protective equipment, but also through the availability of testing if necessary, because when someone has a contact with a patient or a colleague that tests positive for COVID-19, from the beginning of the epidemic in our hospital, we have been testing professionals quite extensively in order to identify them precociously, and after that following them. Right now we also use the serology as a complementary measure, and also as another means of protection is the separation of circuits, either for patients and health professionals, separating those dealing with COVID from those dealing with non-COVID, with clear markings in all those places. So the protection of our professionals and our patients and and the people that come into the hospital is for us a cornerstone of our worries.
Thank you very much. Another question around the relation with the patients and the family, around the way you organize the channel of communication. Do you have anything you have put in place? Can you elaborate a little bit the various dimensions of communication between the hospital, the professionals, the patients, the family, and the community?
Yes, we along the time we had different needs. When the epidemic clearly was installed in Portugal, and a little time before that, we decided to prohibit visits in the hospital. So from that time on, all the patients admitted to the hospital and were in our wards and other settings didn't have visitors for their families or friends. So we had to implement different ways of communication communicating with the families, either the patients themselves through their telephones, but we also provided some forms of communication, but also direct communication of our healthcare professionals in the wards with the families in order to give them the follow-up of what was happening to their patients. Another example is right now that we are relaunching and increasing the frequency of our non-urgent, non-COVID activity. There is the need to talk to patients in order for them to come here and feel safe. So we are calling them and making them the appointments by phone in order for them to be informed of the new rules and of the cares that they have to take, and also make some kind of preliminary questionnaire, clinical questionnaire, to see if there is some kind of complaint that would be suspicious for COVID-19. And also we made also a very important bet in the telemedicine, namely during the period that there was a reduction in face-to-face appointments, we increased dramatically the telemedicine and the phone consultations, and we found to around 1,000 patients a day. We doctors and other healthcare professionals, but mainly doctors, in order to make the consultation and the appointment through this way. 1,000 patients a day, that was during all this time more than 40,000 phone appointments made this way. So we tried to communicate with our patients this way, and also providing in our media, namely in our site and in our social network, the information regarding the pandemic and all the measures that we were taking inside in order for everybody to know what was happening in hospital.
So yeah, this is quite impressive, but also one other challenge many hospitals have faced is that the patients were, afraid to go to the hospital, afraid of COVID. So how did you manage? You mentioned that you had a specific dedicated building for non-COVID patients. Mm-hmm. Is this a place where you had your patients that had low immunity, like dialysis patients and any other that are known to have a limited immune system already because of the disease? Did you have specific change of organization that you made known so that the patient had confidence to come to the hospital without fearing catching up the COVID?
We did that, but not the way you said. One of our hospitals, as I said, Hospital Pulido Valente, is a smaller one, but than the other one, as 1/3 of dimension. We did not move there those kind of patients because it was not possible facing the characteristics of the equipment and all the structure that was implemented. What we did for the patients that were most fragile, namely those ones, the patients with neoplasia, oncology patients, and many others, was to clearly separate circuits within the bigger hospital, because we could not move all this activity to the other hospital. But at the same time, we developed and clearly kept COVID-free the Hospital Pulido Valente in order for the relaunch, for example, of the ambulatory area, namely right now where we are relaunching outpatient consultations, day hospital, and many other ambulatory surgery that we will try to focus mainly in the completely COVID-free hospital, but not saying that the other hospital, Hospital Santa Maria, the bigger one that has COVID, also has non-COVID. So the non-COVID areas are completely safe because the circuits are separate, the patients are identified, the spaces are broadened, and the distance are kept. So we are now trying to do what you said, that is completely correct. People have a little bit of fear of coming to hospitals in general, namely to the emergency room and others. And now we are doing a lot of effort, namely through the media, in order to ensure people that we have put in place a series of security and safety measures that will make the hospital safer than being outside the hospital.
Yeah, thank you very much. Another question about mobilization. You mentioned quite a lot that you had many stakeholders that you mobilized, in the response, but you mostly mentioned those within the hospital. What about those outside of the hospital, the university, the national institution, the funders, national health services outside? I mean, all these national institutions and the universities. How did you deal how the relation was with them, and what was their contribution and role?
With university, we have a partnership because as a university hospital, hospital and the medical faculty of Lisbon, we live in the same space. Many of our professionals are also professionals and teachers in the university, in this case in the medical faculty, and other faculties also have people here within our building. So the university is a partner with us. We also, and not only the university, but also an investigative center that we formed, the Academic Medical Center of Lisbon. So that is our day-to-day living, is with partnership with the university. That was also very solidary with us when trying to make bridges to other entities that could have things to donate to the hospital as protective equipment and other equipment, namely medical equipment. All those stakeholders that I mentioned in the solidarity slide were outside the hospital, private companies, non-profit organizations, sporting entities, and also countries that through the embassies collaborated with our hospital, donating a series of equipments. So those partnerships came in a spontaneous way, and I would like to take this moment to publicly thank all these people as individuals or organizations that helped us. Regarding the other stakeholders in the National Health Services in Portugal, we work as a network. So we are not separated. Each of us has its responsibilities, but the different hospitals in the context of the National Health Services work in collaboration, namely in the exchange of experiences, and if necessary, we as a third level hospital, that is the last stage in the referencing of patients within our system, continued to receive patients from the other hospitals in the areas of non-COVID that we have the expertise.
Okay, thank you. Some other questions that I'll put together around the engagement of the staff and the protection. First, did you have staff that was infected by COVID, and did you take specific measures? For the others, I mean, from the staff, from a general point of view, as this has been lasting for a long time, did you put in place specific measures to keep their engagement over time, you know, quite strong? Because you could expect that there is quite a lot of engagement at the beginning, but like everything, it goes down. And last but not least, did you have to put some specific psychological support for the staff to face this very particular uncertainty and this new situation that they were not familiar with the COVID?
Let's start with the last part of the question. Indeed, we didn't have to put in place the psychological support, because the psychological support emerged from within our own organization. But yes, we did put it in place. But the psychiatry and psychology departments in the organization, in our hospitals, volunteered and put in place a support network for our patients, families, and health professionals in this context. And this was a spontaneous movement, quite natural, that we didn't have to ask. That is very interesting and also very thankful. Regarding the commitment and the continuous feeding of motivation to the people that would eventually get tired, indeed, we tried along the time to always acknowledge, identify, and make visible the efforts of people and try to answer to the needs they had. We tried to show either internally and externally outside the hospital what was being done, putting faces into what was happening, and the faces were from our professionals, and mainly because they were and they are in the center of this response. And a long time, the worry about the infected professionals is something that was born quite early during this period, and we involved from the beginning our health labor department to accompany all the professionals that are either suspicious, either suspect of having COVID or positive, or having contacted with someone positive. And this follow-up is quite intense, permanent, and what we do is test, what we do is identify risk. If at risk, we give the person the possibility of being out, and also accompany with a very intense proximity all that is happening. But from the 7,000 professionals that we have in our university hospital center, we had 82 infected along this time, and many of them, most of them, not within the hospital and not related to the healthcare practice. This is a very good number, because indeed less than around 0.1% of our professionals, and most of them already given as cured right now. So the rate of infection within our healthcare professionals is quite low. We have very few severe cases that we naturally regret, but are being treated. But it is a cornerstone of our commitment and worry as responsibles for the hospital, is not only the safety, but the minimization of infection within the institution.
As we are looking forward, and you said that you were, resuming activities, do you have specific protocols for the patients that come in, especially to make sure that they are COVID-free, like a systematic testing or things like that?
Exactly. Yes, indeed. We have different settings. If a patient comes for an outpatient for an outpatient appointment, we don't test every patient that has an outpatient appointment, but we make an inquiry by specialized nurses at the entrance of the outpatient clinic, in order to ascertain if either the patient or the family that comes with him or her has symptoms that would raise any suspicion of COVID-19. And if yes, those patients or families are directed through the circuit for COVID suspicion patients in order to make the test. All the others have their appointments, and with the safety measures in the waiting rooms, with the disinfection and the systematic disinfection or washing of hands, and also permanently wearing surgical masks. For other patients that are admitted either to the wards, either to a surgery, ambulatory or non-ambulatory, an invasive procedure, chemotherapy, radiotherapy, all these patients are tested for COVID-19 with RT-PCR. They make this screening. So even if they don't have any symptom that would raise suspicion, they are systematically screened. That's one of the reasons why we have so many tests made until now. We make around 404 to 500 diagnostic tests a day within our institution.
So yeah, thank you for giving this clarification about resuming activities. Perhaps the last question, which is more looking forward, is from the experience you have had through this COVID crisis. What are the lessons or what you have put in place that could be changing the way you will be operating afterwards in terms of professional skill, redefining the skill mix and the way the professionals are employed in response to the needs of the patients, in terms of the infrastructure, in terms of the way you organize? Are there already a certain number of measures, organizations that you had to adopt for COVID that you want to implement not only for COVID and beyond this period?
That's that's the major challenge that we will facing in the future, because the first challenge facing COVID was to respond promptly in an organized fashion, but without a long time to think. Now, for the future, we are given the possibility to think more clearly and with more anticipation for what is the future hospital not only post-COVID, because we don't know when will be the post-COVID, but during COVID, but after the major peak. So we are looking at what would the organization need to be in the next months and what would need to stay after that. And one of the major lessons is that we have to be able to have flexible utilization of resources. And not, I don't say definitely, but and with the boundaries and the frontiers within spaces or resources, and use more a shared view of resources, not only human but also physical. So in order to be more flexible in the responses. Another one is that we have to increase the level and the level of response in the critical or almost critical patients, and after COVID we will have a level higher than we had before, even when no COVID patient exists in the hospital. And another one is a lesson from all of us, for all of us, not from, for all of us, professionals in the hospital, medical doctors, nurses, technicians, administratives, everybody, is the importance of sharing and being able to do something that we were not used to do, but we can be called to do. We have had during this a month and a half a lot of people that never did a lot of things, but voluntarily and spontaneously came forward and said, I want to participate, I want to, please teach me, please give me, tell me what you want me to do and I will do it. And this availability, this capacity of people to put in place what they have best is one of the main lessons that I hope nobody forgets in the future.
So thank you very much, and let's hope that this is going to be a way to support further transformation.
Indeed.
By the way, IHF has put together an international task force to work on that currently on what's so-called the next normal or the new normal, to make sure that we can harness and support the good things that have came out from the crisis to continue the transformation of hospitals, and you would be most welcome to join this group if you are available and willing. Let me just summarize a few of the takeaway messages, and please do not hesitate to step in. So first one is that from what you presented is that definitely you have recognized very early that you are moving in uncertain grounds, and that therefore you have to put in place a response that has to be agile and has to put a decision making that is very quick. And that was kind of a framework that you had were able to put in place very, very quickly. And along that, to get prepared with several scenarios, to have several options, especially to expand and scale up the response as it goes. And somehow I would say the way you have responded is to be always one step ahead. That means while you are responding to a situation, you are already getting ready for the next stage. And that seemed to be a very systematic and a very important way for the organization, which didn't need to go all the way up, but was definitely luckily, but definitely was very, very well prepared to grow and in capacity and in response. The other thing that was very well outlined is that you were also very able to identify simple but very strong clinical and administrative process. I mean, you summarize 6 hot topics that was like a backbone to build up the whole response. And I think this was, a way probably to build up a very solid and well understood by everybody response, because you really had 6 hot topics that was guiding the whole organization and the response. The other thing that was important in your response, and I think is a key concern in many countries, is to make sure that the patient don't lose the trust. And you have done it through either keeping specific buildings or more generally by very clear differentiation of the flow of patients, the flow of the circuits, to make sure that there is no crossover and that this is safe and that can be well communicated to be for everyone. And last but not least, is although you had a very specific task force to pilot the response, multi-professional, multi-speciality, as you said, this crisis can only be overcome if there is a general mindset building up response on the team spirit and the importance of team spirit and broad involvement. It is everybody's business. And that is part of a major cultural change, which hopefully will remain if it was not already the case in your organization, but we all need in hospital to have this mindset. Any other concluding remark or messages you would want to change for closing this webinar?
No, I think you summarized it very well, and the closing with the importance of people and their commitment is the major lesson, as you said, from all this route that is not ended yet.
Thank you again, and
thank you very much.
If you have a few last closing information you would want to share.
Thank you very much, Eric. Thank you, Dr. Pinheiro, for the very comprehensive presentation. Everyone, the recording of the webinar will be posted on our website, and you will be notified by email once it's available in a few days. We hope you can join us again in our upcoming webinars. The schedule is on your screen right now, and you can register on our website. Just go to www.ihf-fih.org/webinars. On Thursday, May 7th, Professor Mamuka will give an overview of EVEX hospital strategy on how they're prepared their 18 regional and referral hospitals for COVID-19, the challenges they face, and the emergency action plans they have put in place. So we hope you can join us there. Please keep safe and healthy, everyone. Together we will overcome this global crisis. And thank you very much again for joining us today. I hope you all have a great day ahead of you. Thank you.
Okay, bye. Thank you.
Thank you very much. Goodbye, everyone.